My name's Chris, and I'm a gastroenterologist in Calgary, which is in the Rocky Mountains in Canada. And I had the real pleasure of doing a sabbatical here in 2020, working with Greg O'Grady and the team here, and with Alimetry, just as it started building up. And I'm actually now the Chief Medical Officer, so that's my disclosure. But I have been working on the research with this device and been working in gastroparesis and upper gut disorders for quite a long time. And so it's a real pleasure to give a talk here at the initial meeting of the motility group here. And so very interestingly, the difference between gastroparesis and functional dyspepsia is one that we've sort of debated a lot. And when we came up with the title of this talk, I actually didn't receive the program yet for the New Zealand Gastro meeting. And it turns out Professor Quigley is actually talking on the exact same thing. So it means that we're on the right track. Yeah. We're talking, at least we're on the right track, that really that this is a big deal, trying to figure out what is the difference between gastroparesis and functional dyspepsia, because it does make a big difference, at least we think it does, in terms of what those diseases are and how you treat them. So in GI, there's four kind of big disorders that are the gastric ones that we see. Some people see it as the four horsemen of the apocalypse. These four different disorders that are actually kind of hard to treat, that are poorly understood, and for the most part are just based on symptoms and a history, with the exception of gastroparesis, which we use the gastric emptying test. And I won't say too much about them, but by far functional dyspepsia is the one we see the most of. It's particularly the simple kind, the garden variety functional dyspepsia that responds to maybe PPI or prokinetic. But when it gets to the more severe end of the spectrum, that's where it really starts overlapping with gastroparesis, and it can be very hard to know if this patient with postprandial distress and maybe some vomiting and a lot of disability, is it just functional dyspepsia that's really bad, or do they have an organic neuromuscular disorder of their stomach? Now, cannabis hyperemesis I won't talk about too much. It's a big deal in Canada, where cannabis is now fully recreationally legal. We're seeing a ton of that, maybe less so here. And then CVS is also overlapping quite a bit as well. So when you talk about gastroparesis, it's kind of like, Alice going down the rabbit hole. We know that it's a situation where the stomach is not working, and it can lead to delayed emptying and a lot of symptoms. But other than that, there's still a lot of uncertainty about what it truly is. And common causes, of course, are diabetes and post-surgical and idiopathic, which is actually probably the majority that we often think are post-viral or other causes. But there's no question that a lot of idiopathic gastroparesis probably contains a lot of what we think of as a functional disorder, a lot of visceral hypersensitivity there. But we don't know because we don't have particularly good tests. Now, in the worst case scenario with gastroparesis, we know that you get histological damage. We know we get structural damage to the muscle or the nerves. And so, there's actually a classification, the London classification, where you can do a full thickness biopsy of the stomach or the gut. You can say there's a neuropathy there, or myopathy, or capillopathy. But the reality is that, first of all, it's very invasive. And so that's why we don't do these full thickness biopsies a lot. The other thing is that by the time you get histological damage, often it's quite advanced. And so, even if there is a disease process going on, you may not find this until it's pretty well advanced and maybe beyond repair. And sometimes I tell people, with their symptoms, they ask me, should I get a full thickness biopsy? It's kind of like if your laptop crashed, it's like biopsying the hard drive or something. It's not going to tell you why it crashed. It's a software problem more than a hardware problem in many cases. But what worries us all is these organic neuromuscular disorders. Okay, and so this is a patient of mine, 33, went to Thailand, got sick after eating some street food, and was told that his chronic nausea and vomiting and diarrhea was actually just post-infectious IBS and dyspepsia. But then a few years later, of course, you could see that his gut is all fully dilated, stomach as big as Maggie, and so this is a catastrophe in the sense that once you get this kind of dilation and damage, that ship has sailed, in terms of fixing it. And so we need to be able to figure out who's going to progress to this. Conversely, the good news is that not many people do, But probably the biggest thing is also the reverse. People who've been diagnosed with gastroparesis, and they might not actually have major damage to their stomach. It's just more like functional dyspepsia. So the way that these days, for the vast majority of patients, it all hinges on the gastric emptying test. And so, as you know, it's a test where you eat a radio-labeled meal, usually an egg, and they measure how long it takes to empty out of your stomach. And we know that the cutoff mostly is the 4-hour number. How much is retained at 4 hours? More than 10% is the criteria for gastroparesis. And so it really kind of becomes a binary thing. Like either your stomach is slow and it's broken, or it's normal and everything is fine. And the reality is it's probably not the case, that there's probably a lot of dysfunction that can happen that doesn't follow this paradigm, okay? And so, you know, the other thing is that often the test is not done correctly. It doesn't use the standard meal. They don't image it out to the right amount of time, or they use liquid emptying, and none of those are really well standardized at all. So what it all comes down to is this paper by the NIH consortium, Gastroparesis Consortium, that found that gastric emptying and symptoms don't really distinguish that well at all between severe functional dyspepsia and gastroparesis symptoms. And so they did a study with many hundreds of people where they followed people who met criteria for chronic nausea and vomiting syndrome, and they either had slow emptying and they were called gastroparesis, or they didn't and they were called functional dyspepsia. And they followed them for a year, and they repeated the tests, and they found that huge proportions of the people who were previously slow were now normal, and another big tranche that were previously normal were now slow. And so what that tells you is that there's really no way to use emptying reliably over time anyways, to say how wrong things are or what's going wrong with the stomach. So we'll come back to that thing. So medical management, I won't spend much time on. And you know, the reality is that a lot of the first-line treatments for functional dyspepsia and gastroparesis can be the same. But it means drug trials. It means going through different things, you know, trial and error, side effects, and time for the patient. You know, how long does it take to go through 3 drug trials? It takes well over a year, and they may have side effects. But of course, globally, domperidone is probably the first line that we use outside of the United States. Prucalopride is definitely a good medication if you can get it. Not on the national formulary here, as I understand, but it is generic now, so more affordable. And interestingly, the 2 milligrams versus 4 milligrams is interesting, because that's 2 trials that I was involved in. The 2 milligram was done in idiopathic gastroparesis and was very helpful. That was done in Belgium with Jan Tak. The 4 milligram trial was done in Calgary with us, and we did the diabetics. And even though it increased gastric emptying, it's a prokinetic, of course, even though it increased gastric emptying, it didn't make their symptoms any better. So with prokinetics, you know, there's a sweet spot, as you probably know. So things are too slow, you get nauseated. You drive them too fast, you get nauseated. So you try to find that sweet spot. And so 2 milligrams looks kind of like the sweet spot for the dosing for that. Lots of other things. And obviously this is a whole talk in itself that I won't carry on with, but neuromodulators, mirtazapine, aprepitant, all been studied and can be helpful. But ultimately, you know, especially if you're an interventionalist, we like interventions. We like definitive solutions to things. And if the concept is slow emptying, then you can definitely improve emptying by injecting Botox or doing a G-poem or considering doing an Entera. But again, this all hinges on trying to diagnose who actually needs a drainage procedure or who actually needs neurostimulation, because they're very different approaches. And so at this point, it's very hard to know what the difference is. And so, as you can imagine, if you have really severe functional dyspepsia, doing a surgery may not be ideal. And so this is where body surface gastric mapping comes in. And as you know, the stomach makes slow waves of electrical activity that go in this beautiful, nice, smooth fashion from the pacemaker area on the greater curve down to the pylorus. And there's often multiple wavefronts going on at the same time, and you can map that on the on the body surface, on the abdominal wall. And so based on this concept, the team at Telemetry here has been actually working for a very long time to try and get a way to measure this easily and clinically. And that's where the allometry test comes in. And I'm sure these folks will tell you all that you want to know about it. But it's essentially an array, an 8x8 electrode grid that goes over the stomach and is attached to a reader that you wear. And then the patient logs their symptoms on an app, and it actually measures the electrical signal over time. And the test is pretty straightforward. It's actually very similar to a gastric emptying test. So once you've laid on that electrode array, you have a 30-minute baseline, and then you have a standardized meal, which is something like a Cliff Bar and Onshore or water. And then you measure the electrical activity for 4 hours after that. Okay. You also simultaneously track symptoms on the app, and that is then put together into a report that can give you a number of biomarkers as well as a detailed symptom output. And so this is a whole talk. Of course, I only have 15 minutes total, so I'm going to have to run through it. But there's a number of biomarkers that are of interest, and the frequency. This is a spectral plot, and what this is showing you is the frequency of those slow waves happening in the stomach. And you can see on the left, which is the fasting state, the stomach is quiet. Then they eat the meal, and you can see that the amplitude of the electrical activity ramps up, and you get a nice smooth 3 count per minute wave. And that's very similar data that traditional EGG would give you, electrogastrography. But there's many advantages to this, and particularly in terms of artifact reduction and removal, as well as biomarkers that can tell you things that we weren't previously able to know. And some of those things would be the rhythm stability, the allometry rhythm stability, or the Gary. And that tells you how well this frequency remains at 3, the dominant frequency. We also can look at the amplitude. Okay, so in certain cases, if there's not a lot of amplitude, that can suggest muscular weakness or damage. And then you should also see a good meal response after eating the meal. We also have some other spatial type of biomarkers that I don't really have time to get into. But overall, it can put it into a package for you that can show you a number of different phenotypes that are clinically valid. So just to put it together, to visualize what you're seeing. On the left, you can see this is invasive measurements of the gastric slow waves, okay, when you actually laid it on the serosal at an operation. And you can see that on the left, when you get these nice, smooth, stereotypical waves, you get a nice smooth line at 3 counts per minute. And that's what you should normally see in the stomach on the body surface gastric map. But when you have a neuromuscular disorder, or what we think is gastroparesis, you can see that the depolarization is really abnormal and very similar to like a fibrillating heart, although it's probably not as fatal, of course, with gastroparesis. But the idea is that you can see that those waves are going backwards, they're going in loops. And so that gives you a real mess on the spectral analysis. And we call that the neuromuscular phenotype. And we are showing, and I've preliminary data definitely holds this up, that the neuromuscular disorders do correlate with what we think is gastroparesis, is that neuromuscular damage to the stomach, as opposed to a visceral hypersensitivity problem or a centrally mediated problem. And based on those phenotypes, we were actually able to do a study of chronic nausea and vomiting patients matched to healthy controls, and where they all had chronic nausea and vomiting symptoms, and about half of them had gastroparesis with slow gastric emptying. And this was, Armin was the first author on this, and we just got it published in Science Translational Medicine. And very briefly, about 60% of the patients in this group had a normal BSGM. Okay, and so some of the patients that we thought were gastroparesis actually had a normal BSGM. And so we think that maybe these ones are actually more a functional dyspepsia type phenotype. And then about 48% of them actually had a neuromuscular disorder. And so that it was actually really reassuring to see this, because we know that at least some of these people in this cohort have a neuromuscular disorder, but there's no way to tell which ones, and even doing the full thickness biopsy may not tell you, but the body surface mapping may be able to distinguish, and might be a new paradigm to actually say, okay, if your BSGM is abnormal, you have gastroparesis. And reassuringly, this was kind of validated by looking at these symptom plots. And so what these show are the correlations between the outputs in orange, which are the BSGM metrics, and the symptoms, which are in purple, down on the right-hand side. And so the people who had normal surface mapping, their symptoms correlated with depression and anxiety scores, but not any of the BSGM endpoints. But when you look at the ones who had abnormal BSGM, most of their symptoms did correlate with these markers. And so what that tells us is that the people with normal BSGM, who we think might be more the centrally mediated or visceral hypersensitivity patients, definitely have higher anxiety and depression, and that's in fitting with exactly what we think functional dyspepsia is, as defined by Rome. But on the other hand, the smaller number of ones who had abnormal BSGM, their symptoms really did correlate with the abnormalities that we saw on the mapping. So overall, we think that this could be a very robust test to help distinguish between gastroparesis and dyspepsia, as well as a number of other potential gastric disorders that we may not have even think about. So gastric emptying studies definitely have its pitfalls, but since it's the only game in town for most of us, most of the time, we still use it. But it still is difficult to know when you've got these patients who are really symptomatic, would we be better just treating you like a chronic pain patient, or do we need to get into sort of tube feeds and sort of drainage procedures? But there's no question that the new technology is something there's a lot of work going on in it, and I'm certain that we will find out a lot more in the days and years to come. So, thank you.